to be here for this SSBMT webinar series, which it will be for 1 hour, and it's about introduction and overview of sickle cell anemia cases in Saudi Arabia. Then Dr. Julia Kanter will present how I treat sickle cell disease with recurrent VOC. I would like to thank our sponsor for this SSBMT series, who's Novartis and Takeda. And for today webinar, which will be about for sickle cell disease, I'd like to thank the sponsor, Novartis. And also I would like to thank the organizing committee and Dr. Al-Askar and Noor for giving me this chance to be organizing here. Dr. Julia Kanter, she's associate professor and co-director of comprehensive sickle cell center in University of Alabama in Birmingham. She did her pediatric residency in Colorado, and she did hemato-oncology fellowship in Washington Lewis in 2009. She also she's currently certified for both American Board for Pediatric and American Board for Hematology and Oncology. She has a lot of awards and honor. She's actually co-chair for American Society of Hematology for Sickle Cell Center workshop. So we're going to start by a brief introduction and overview of sickle cell anemia in Saudi Arabia. As you know, that this is a mechanism for sickle cell disease. It's actually due to change in amino acid in glucose in chromosome 6. It's replacement of glutamine by valine, which will lead to sickling. Sickling. So this is a picture will give you an overview for mechanism of sickle cell anemia. That's the new medication is targeting those sickle. So you can see there is an inflammatory stimuli with endothelial cell activation and desactivation, which will lead also to pro-inflammatory and cytokine production and activation of coagulation, which will lead to sickling and hemolysis and occlusion of microvessels. Actually, our data in Saudi Arabia about sickle cell disease epidemiology is very poor. This is an article by Dr. Justinia, who gave us the prevalence of sickle cell gene in adult population. It was during premarital screening program, which show around 4.26% of population are sickle cell trait, and only 0.26 are sickle cell disease. The highest prevalence in the Eastern region is around 17% of population are sickle cell trait, and the indigenous experience in sickle cell in Eastern region, it showed around 21% of newborn screening there. They have sickle cell trait gene. Unfortunately, in our premarital screening program, they're doing their best, but still almost 90% with high risk marital status, they declare they decline. They declare that they are going to get married despite of high risk. This, with education in Saudi Arabia, get down to 60% in the last 6 years. So as we know that there is many variable, there's many haplotype for sickle cell disease. We have Arab Indian and Benin type. Actually, in Saudi Arabia, Eastern region, they have in the Eastern region, they have the Arab Indian, which is benign type, Actually, in South area region, in Jizan and Najran, they have the more severe type, which is called Benin. Actually, they have more acute chest syndrome, and they have more CNS crisis. So, some haplotypes getting more severe, like Kara and Benin type. Arab Indian usually is mild disease. If patient has hemoglobin F, acquired hereditary hemoglobin F, they will have mild disease. If they have alpha gene, also they will have milder disease, which will lead to a less hospitalization. Actually, this is a cost of sickle cell disease in general for one person. It's around 8 million for one person for whole life. So we have many challenges for sickle cell disease in Saudi Arabia. Actually, we have shortage of hematologists. I think Saudi Council 3 or 4 years ago, they said they have only 60 hematologists in Saudi Arabia. I think with the new fellowship programs, the number will get increased. They have also a shortage of supporting staff, blood supply, and blood banking issues. It's always in Ministry of Health an issue. There is an interruption for critical medication like hydroxyurea, iron chelating agent. I think there is a plan now for national neonatal screening program, which is not started yet in Saudi Arabia. We have limited access to transcranial Doppler, and we have limited number of BMT, bone marrow transplant center for sickle cell disease. And actually, the new medication will be very costly. This is in general the complication for sickle cell anemia. It could be cardiovascular complication, include left ventricular hypertrophies, heart failures, acute chest syndrome, pulmonary hypertension. It can lead to nervous CNS complication, which include CNS crisis, stroke, epilepsy. They could have cognitive impairment. The reticuloendothelial system complication like splenic sequestration, hemolysis, and anemia, and also hepatobiliary complication like gallbladder stone, sickle cell hepatopathy, proteinuria in urogenital system, and of course, vascular necrosis and leg ulceration. So by age of 50, by age of fifth decade, almost 50% of sickle cell anemia, they'll have end organ damage. So they could have sickle cell retinopathy, nephropathy, pulmonary hypertension, and vascular necrosis. So this need to be treated early, discovered early, and to manage properly. So this is called like a health maintenance for sickle cell disease. We have to have an early diagnosis by newborn screening, which is now, I hope that within 1 or 2 years will be initiated in Saudi Arabia. The aim of that to detect them early, to screen them with transcranial Doppler early, and give them pneumococcal vaccine, pneumococcal prophylaxis, include penicillin, pneumococcal immunization, transcranial Doppler to prevent CNS crisis, proteinuria screening and blood pressure control, of course, retinal examination and screening for pulmonary hypertension. If you have a sickle cell comprehensive program, you could make some KPIs for your centers. This is slides that can give you what we need for each sickle cell anemia. You have to count his ER visits, hospital admission, medication adherence, his penicillin, prophylaxis, immunization, vaccination, and you can make checklists for those. And follow them regularly. I will not go in details for management of sickle cell anemia, but we have to define that there is a chronic issue management and acute complication management, and there is clear indication for stem cell transplant. Of course, hydroxyurea should be started for all patients at age of 9 months because it found that decrease the morbidity and mortality and decrease the sickling and decrease the CNS crisis and prevent end organ damage. So this is an acute complication for sickle cell anemia. The most common is painful crisis. They have to manage it appropriately and with good pain control. The most serious complications, acute ischemic stroke and acute chest syndrome. They have to be discovered early and they have to be managed as soon as possible. So CNS complication, we mentioned it. Silent infarction by age of 20 years, almost, we can say almost 50, around 40% of children, they have silent infarction without any symptoms. So acute chest syndrome management, usually supportive, is like any patient with pneumonia, but they have to be managed aggressive with broad spectrum antibiotics and consider exchange transfusion early. So the most important message in each slides, in each presentation, I said, do not wait for exchange transfusion for acute chest syndrome. If you have a patient with acute chest syndrome, transfuse him with the blood, then consider exchange transfusion later. One of the most common complications we see it is post-transfusion hemolysis, or what we call it hyperhemolytic crisis. This hyperhemolytic crisis, actually, you give blood, patients going to have more hemolysis. You give him 2 units, hemoglobin will drop more. Those patients, they might need to stop blood transfusion, give them IVIG, give him high-dose steroid, give them erythropoietin, and avoid blood transfusion if they are hemodynamically stable. Sometimes blood transfusion in those cases with significant antibodies can be harmful. So this is an article was published in Bone Marrow Transplant. It's a commentary. Sickle cell disease is not so benign. It's not benign disease as we expected. Actually, in Saudi Arabia, a number of sickle cell disease who died, I think, is more than acute leukemias, sickle cell death and thalassemia death, more than most of acute leukemias and other hematological disorders. So there's an indication for a transplant. We could say that recurrent VOC more than 2 years, patient with recurrent acute chest syndrome, patient with a stroke, patient with cognitive impairment or abnormal cerebral MRI, patient with pulmonary hypertension, patient with sickle cell nephropathies. Those has indication for sickle cell transplant. And when patient has a stroke, it's mandatory to transplant him, because actually if they have stroke, the recurrent of the stroke will be, patient will have recurrent stroke despite of blood transfusion. So this is a study by Dr. Sultan. Total number of Saudi patients with sickle cell disease who are candidate for transplant, it's around 10,000 for adult and pediatric. I don't think that there is any transplant center can do that. Right now we have around 50 to 70 transplant a year in Saudi Arabia. That's estimate. I'm going to present the National Guard experience for stem cell transplant. Their program started 2015. They use non-myeloablative conditioning with CAMPATH TBI 300. They use sirolimus as GP as graft versus host disease prophylaxis, and they use peripheral stem cell collection. Actually, this slide is by Dr. Mohsen al-Zahrani. I'd like to thank him here because he did great job in Saudi Arabia in sickle cell transplant in Saudi Arabia. So the most referring center was Prince Mohammed bin Nasser from Jizan. They have transplanted around 100 cases. This is their protocols: alemtuzumab, TBI, followed by sirolimus and stem cell infusion. Their overall survival was 94%, and this is the original protocol by NIH and was published in 2014. So this protocol used in National Guard. They have around 100 patients. Their age from 14 to 42-year-old. They are all in hydroxyurea. The indication for transplant acute chest syndrome, VOC, and CNS crisis in around 26%, CNS vasculopathy like Moya syndrome in 9%. This is their clinical crisis. They use there is only around 8% graft failure, and their outcome was great. Actually, the event-free survival was around 90%. So their median follow-up was from 2 days to 1,500 days. Their event-free survival in 2 years is 85%. Overall survival for sickle cell anemia is 97%. So this was great. Most of them, they have been discharged from the hospital without significant complication. Their 100 days graft versus host disease was 0. Their hemoglobin level is normalized. At 1 year, their hemoglobin around 12. Hemoglobin S went down to 30 to 40%. It's like a donor hemoglobin electrophoresis. So in general, they have around 100 cases with good outcome. Their mortality is very low, with excellent event-free survival. So now in the futures, which Dr. Kanter will talk about, is new drugs in sickle cell anemia. So for me, I end here, and now it's my pleasure again to introduce Dr. Kanter. Dr. Kanter will be talking about sickle cell, how I treat individual with sickle cell disease who has recurrent VOC. Dr. Kanter, the mic is for you, and thank you.
Thank you very much, and thank you again for having me today. It is certainly my honor to discuss how I treat individuals with sickle cell disease with recurrent vaso-occlusive crises. Some conflicts of interest that aren't relative to today's discussion. So we're going to increase our understanding of the pathophysiology of sickle cell disease. Thanks to the introductory discussion, this can be a little bit shorter, and we can move on to the causes of pain and recurrent vaso-occlusive crises. And then we are going to talk about some cases so that we can explore potential therapies for those individuals with recurrent vaso-occlusive disease. So I always like to remember the pathophysiology of this disease, because for so many years, we really thought that it was all about the red blood cell, right? It was just this red blood cell that was mal-shaped and got stuck in the blood vessels. And we really understand now, of course, that that's not really what's happening. And it's so much more complicated. And instead, we know that it's about the hemolysis, and that all of this free hemoglobin that occurs down in that bottom picture really causes nitric oxide to be used up, which causes the blood vessels to be abnormal and respond abnormally, as well as significant inflammation, influx of neutrophils, white cells, and platelets. And we have to think about how much inflammation relates to pain in sickle cell disease. So here, when we think about a vaso-occlusive episode, very important again to think in this top portion where we think about the inflammation, the platelets, the white cells that all contribute to that vascular adhesion. And together, downstream, we get microscopic vascular occlusion and tissue hypoxemia. However, in some cases, you may not have significant vascular occlusion, but you may have significant endothelial damage from previous crisis or previous areas of vascular occlusion. The endothelium becomes abnormal, more adherent, and more permeable. And so those individuals will have swelling and other problems with their blood vessels that can also result in pain and can sometimes be mistaken for a vaso-occlusive episode. As we really just discussed, the degree of organ complications in sickle cell disease is unfortunately unlimited. There's not an organ or body part that is not affected by sickle cell disease. I remember as a resident first seeing a young man who came in frequently for vaso-occlusive crisis of the scalp. Initially, I think people thought he was faking it or perhaps wanting to get out of school. But as you looked closer, you could see that he had vaso-occlusive infarcts and bone infarcts of his scalp. He would get significant amounts of extravascular adhesion and then fluid leakage, and have incredible pain on his head to the point that he could barely lay on a pillow. So it's always important to recognize the different areas of the body that can be affected in sickle cell disease. And that while we understand that there's this single gene mutation that's responsible, there is so much phenotypic diversity. It's not accounted for by the genotypes or even the haplotypes. We just don't completely understand why individuals display such individual symptomatology. So we know there must be other genetic polymorphisms and differences in gene product function that are contributing to this complex physiology. So while we know there's patterns of this disease, we have to recognize that every patient is different. And this is especially true when we talk about pain. Pain in sickle cell disease. Truly the hallmark feature of this disease. It's the primary reason we know that affected individuals seek care. It starts off as an ischemic pain secondary to vaso-occlusion, but over time becomes increasingly ubiquitous, present throughout life, and that pain changes. Generally speaking, when we think about the epidemiology of pain in sickle cell disease, we want to divide it into two different groups. The vaso-occlusive crisis, or sickle cell crisis, known as an acute pain attack and vaso-occlusion, is the hallmark symptom. This is what we think of the most. And then we think of chronic pain, much more difficult to understand. Here it's multifactorial. Some individuals have things like avascular necrosis or leg ulcers that are clear-cut causes of this chronic pain. Others have neuropathic pain. Then there's others who develop this hyperalgesia that we don't completely understand, where even normal touch and normal sensations begin to cause pain. So again, when we think about pain in sickle cell disease, we have to recognize how much of this pain is actually seen and how much of it is experienced that we as the medical community don't see. Research has shown that the underlying burden of pain is higher than most clinicians are aware. In one study called the Pisces study, of approximately 31,000 diary days, pain was actually noted on 54% of those days. But of course, these individuals did not come in for care all of those times. And in fact, unscheduled healthcare was only 3.5% of those days. So these individuals are having far more pain than they're coming in to see us for. So now what we know is that pain in sickle cell disease is poorly understood and highly variable. It's not very well explained in different groups. There's genotype and biologic traits, but these only explain part of these variances. And little is known about differences in different people's response to pain and pain medication. So let's talk about survival by pain rate. Why do we care so much about pain? Well, this is an old article from 1991, but it still holds true. It's from the Cooperative Study of Sickle Cell Disease, where they followed a number of individuals. And what they found was that the more times patients came into the hospital, more times that they needed actual acute care for their sickle cell disease mediated pain, they were more likely to die younger. Now, there's likelihood that this is somewhat due to sickle cell disease, but also probably somewhat due to the effect of being in the hospital. We know that the more you're in the hospital with these recurrent crises, the more times you may develop acute chest syndrome, the more times you may have an infection or a blood clot or other complications from being in the hospital. So we have to address these recurrent crises because we know it can lead to additional morbidity and mortality. When we think of pain, we have to remember there are multiple dimensions of pain. And the social and cultural experience of pain can be very different depending on where you're from, who your family is, what your social identity is, what your peer support and pressure is. Pain is also affected by your emotions and your motivation. Are you depressed and now there's pain? Are you upset and now there's pain? Or what about your past experiences? A lot of individuals who've had severe outcomes secondary to a bad vaso-occlusive crisis become very anxious about pain. And so their response to what might be a minor crisis is heightened because they become so scared. So while the same tissue damage may occur, this could be the same vaso-occlusive crisis in the left leg, everybody may have a different response to this pain, depending on their baseline emotion, their anxiety, their past experience, and then the family expectation and support system. So when I think about individuals with pain, I think about all of these different things. Where and when is that pain occurring? Are there triggers of pain? And what is that individual doing now to help manage their pain? How is the baseline mental health of the individual? Probably one of the very most important questions that we can ask. What are their motivations? What are their beliefs? What are their values? Who is their support system? When someone has pain or a vaso-occlusive crises and is trying to take care of themselves, who helps them manage? Who helps treat them? Who enables their kids to be taken care of while they're having pain? I also have to look at what types of therapy people are interested in pursuing. What kinds of medications are they willing to take? And how can I help get them to buy in or engage in treatment? So now let's take a couple of individuals' cases with recurrent vaso-occlusive crises and explore this in a little more detail. Of course, I've changed all these details to protect the privacy, but these are all based on real individuals. Let's talk about Morris. Morris is a 23-year-old with hemoglobin SS disease. Overall, through his childhood, he did pretty well. He graduated from high school and attended welding school and is now working as a welder. And in the last 2 years, we noted he's been coming more and more to the ER and requiring hospital admission due to pain. He's actually referred to my Sickle Cell Center for evaluation after one specific prolonged hospitalization where he was diagnosed with acute chest syndrome and a pulmonary embolus. When he gets to our center, we always start off with asking, when's the last time you were seen by a physician, a sickle cell specialist like us? In his case, he was last seen by a pediatric hematology around 12 years of age, he thinks. He doesn't remember going back after that. When asked why, as is common for many individuals, he says, I felt well, I had no problems, so I did not need to go to the doctor. He'd had his gallbladder out at age 11 and has had acute chest once at age 5, but had done very well through his adolescent years. So we talk about his goals of care, the current living situation and social situation, and what is his motivation, and does he want to improve? So he really enjoys his current job and he has a girlfriend. He's very frustrated when he has pain and can't manage it at home. He wants to make sure he won't lose his job. He has lost previous jobs because he's missed work. And at home, he has no pain medication except for whatever the emergency room last gave him. And he thinks that when he has pain medication at home, he can often manage his pain. He really knows very little about sickle cell disease, doesn't understand how it affects his body, doesn't understand the importance of things like healthy eating and hydration. We talk about different disease-modifying therapy and options, and about a pain management plan. Now remember, Morris hasn't been in care in over 10 years. He's never taken hydroxyurea or had other similar medications. And we end up spending about an hour just really explaining how sickle cell works, because as an adult, he's never heard this discussion. So after discussing all of the different options, he's very interested in starting hydroxyurea. Whenever I discuss the options now with the new medications that are available, I include hydroxyurea in that discussion. When people say, what do you recommend the most? Well, hydroxyurea is the most known. We know the most about it and have the most experience. And he says he wouldn't mind taking a medicine every day. He thinks he can do that. And he's not worried about taking medicines like some patients say. We talk about the importance of preventative care, especially about eye exams. I always tell patients of my stories of individuals who've gone blind because they just don't get their eyes checked. We talk about monitoring his kidneys, and he sits up straighter because his grandmother died of renal failure and had been on dialysis. And he agrees to come in monthly until we get him feeling better. So as was just discussed, hydroxyurea is still the first FDA-approved medication for sickle cell disease, can significantly improve outcomes in adults and children. Originally, it was used in only those individuals who'd had more than 3 crises per year. However, now we recommend hydroxyurea to anybody with a diagnosis of sickle cell anemia starting around 1 year of age. We've also noted that maximal tolerated doses may not be needed. We don't always need to push people to their highest dose. And pediatric studies have proven it's just similar safety and efficacy as adults. But we also know that it's just not for everybody. And for a number of reasons, we have individuals who don't want to take hydroxyurea or cannot tolerate it. So now let's talk about Mabel. Mabel is also a similar patient that I see all the time in my clinic. She is a 27-year-old female, and she has SS-type sickle cell. She lives with her mother and her 2 kids. She did finish high school, but she'd been on disability since she was young, and so she never got a job because then she would lose her disability check. A common problem here in the United States. She has been taking hydroxyurea, except while she was pregnant, since she was 7 years of age, but feels like it's not helping her anymore and she wants to stop taking it. And of course, when you look at her labs, you realize she probably has already stopped taking it in the last 6 months. She's come into our clinic recently, several times. We have an IV infusion clinic where she can get pain management, and yet despite coming in almost weekly, she still goes to the emergency department very frequently. Since she's seen often, she's very up to date on her screening exams. When we look at the rest of her past medical history, she's had her spleen and her gallbladder out. She snores at night and doesn't sleep very well. She has a port. She's had several transfusions through her life during her hospitalizations and has a lot of alloimmunization or antibodies to blood cells. So as we did before, we need to really look at her goals of care. What's her living situation and social situation? And what is her motivation? What kind of interesting therapy would she be willing to do to help her get better? She's a pretty angry young lady. She's frustrated. She really just wants us to give her more pain medication. She feels like she had more pills at home, she would be better. And she's just overall fed up with her sickle cell disease. We spend a lot of time talking about how going to the ER and being admitted can be very high risk and how it could increase her risk of dying an early death. This does kind of catch her attention. She's not worried about going to the ER, but when you talk about her kids, she smiles and says, I gotta be around for them. And notes that when she has pain and she's at home, she can't manage her pain easily because nobody will take care of her children for her. However, when she goes to the ER or the hospital and tells her family members that she has to be admitted, then her family will help her. She can't sleep well at night. Maybe she sleeps a few hours at a time and she snores a lot. So we talk about a lot of different things. And again, Mabel is a very frequent patient that I take care of. We do talk about new disease-modifying therapy, such as crizanlizumab, that could decrease her acute crises. We talk about taking hydroxyurea, setting a phone alarm to make sure that she takes it every single day. And of course, helping her understand that hydroxyurea doesn't work if you don't take it every day, but that we certainly know some people don't respond to hydroxyurea. We also have a case manager that we use for very high-risk patients, and we assign her a case manager to help check in with her a little more regularly, help her stay on top of her medications. We talk a lot about a healthy lifestyle. She actually drinks a lot of Mountain Dew, doesn't spend a lot of time drinking water. We talk about the importance of hydration and water. And then we talk about evaluations that might help her. We often see the lack of sleep contributing to severe pain in our affected individuals. And so we talk about that she needs a sleep study. Maybe she's not breathing well at night, she snores, perhaps she has obstructive sleep apnea. And we certainly know the less you sleep, the more pain you have. We talk about counseling. She's very stressed. She really feels like she has no help at home. Though she lives with her mother doesn't help with her 2 young kids. And as I said, the only way she can get help when she doesn't feel well is to be admitted to the hospital. And we talk about that she really needs to have a conversation with her family about keeping her out of the hospital, but also helping her manage her pain and her life. So we resolve that she is going to start crizanlizumab, and she likes the idea that crizanlizumab is a monthly intravenous infusion to help decrease her pain crises. She is less enthusiastic about continuing hydroxyurea. She is convinced it is just not working. But she says, if I don't have to take as many pills every day, I'll continue to take it. She's been taking 4 pills a day, so she agrees that if we decrease it to 2 pills a day, she'll more consistently take it. She agrees to have a medication to help her sleep, as well as to have an assessment by sleep medicine to see if she might have obstructive sleep apnea. She's really not excited about getting counseling. She feels like it's just not needed and mental health is for others, but not for her. But she does agree that she needs help at home. She's scared to talk to her mom by herself, but agrees that if her case manager will come with her, she'll talk to her mother about helping her manage her pain so that she can stay home and not feel like she has to come into the hospital. So let's talk about crizanlizumab. Crizanlizumab is one of the newer medications that has recently been approved in the United States. It is a P-selectin inhibitor. We know that P-selectin plays a role in the pathogenesis of sickle cell disease, which can lead to sickle cell pain crises. It's a humanized IgG antibody that inhibits P-selectin. And in the SUSTAIN study, which was a phase 2 study in which individuals were randomized to receive a high dose, 5 mg per kg, crizanlizumab, a middle dose at 2.5 or placebo, we saw that those on the high dose had a decrease in their vaso-occlusive crises by 45%. When we looked at these data, and sliced and diced it, we still found that individuals who'd had up to 10 crises in the year prior had a significant decrease in vaso-occlusive crises with the use of crizanlizumab. Very effective. This is likely because it helps the endothelium and prevents the blood from sticking to the endothelium, as opposed to just maintaining the health of the red blood cell, and therefore can be used in conjunction with other medications, such as hydroxyurea. Now we're going to talk about the hardest patient in my group. This is Roberta. Roberta is a 31-year-old female, and she has hemoglobin SC disease. About 30% of our patients here have SC disease. She lives alone, but her family lives here in town. She did finish college, and she works for herself in designing jewelry. She has traveled to several states and had several doctors over the last 5 years, several very good doctors, but feels that no one understands her, no one listens to her, and no one is helping her with her pain. She is hospitalized monthly, often staying for 7 to 10 days at a time, but often says, it doesn't help, my crisis isn't better. She's tried hydroxyurea, doesn't think it works. She's taken long-acting pain medicine, feels like it makes her tired, and she's taken L-glutamine, but didn't like it because it was gritty when she drank it. She notes that she's depressed, she's always tearful in our clinic, but refuses mental health. When we look at the rest of her history, she's had ovarian cysts, she's mildly obese, and she has a port because she has poor access for pain infusions. So again, we look at the goals of care. This individual is probably the hardest individual that we have to treat. It's unclear that she really wants to feel better. She is interested in making her business succeed, but she doesn't have much motivating factors or interest in actually improving. She kind of likes being in the hospital. She lives alone and her family is supportive, but she doesn't have other healthy supportive outlets. Most of her friends have sickle cell disease, and she mostly enjoys working with them via Facebook in ways to advocate for others with sickle cell. So we talk a little bit more, and as I mentioned, she is not worried about going to the ER. She really has very few other responsibilities. And we talk about all of the different options. Again, we talk about crizanlizumab to decrease frequency of acute crisis. We talk about retrying hydroxyurea. We talk about exchange transfusion therapy. And we discuss possible chronic pain syndromes. And what we try to impart upon Roberta is that she has pain that is above and beyond what we would consider normal vaso-occlusive or sickle cell related pain. In fact, she has chronic daily pain, and it's unclear that she can differentiate her severe chronic daily pain from her sickle cell disease vaso-occlusive pain. So it's very difficult to understand when she's truly having a crisis and when she has an exacerbation of her chronic pain. Eventually, she decides that exchange transfusions would be helpful. She notes that she did this between 18 and 20 years of age and found it useful when she was trying to get through college. Does not agree that she is opioid non-responsive. We have a lot of talks with individuals, especially here in the United States, where we have a lot of opiates. that sometimes they don't respond to opiates, and opiates aren't the entire answer. But she wants to try a new long-acting opiate. She doesn't want to agree that opiates might not be optimal for her. She absolutely refuses hydroxyurea and refuses counseling. And we talk about other adjuvant treatments for pain, especially chronic pain. So in this case, we talk about Cymbalta or duloxetine that has some antidepressive effects as well as some chronic pain medication effects. And she is absolutely unwilling. So we put her on exchange transfusions, and we've been keeping her S and C combined at less than 15% on a monthly basis. She eventually agrees to take the duloxetine, but states it doesn't work. She continues to refuse hydroxyurea, but is interested in adding crizanlizumab because she's seen other people on Facebook using crizanlizumab. This time, after she continues to have repeated clinic visits and ER visits, always for recurrent pain, we insist on counseling and actually insist that if she does not start getting counseling, we will no longer prescribe opiate medication for her. We talk a lot about chronic pain and the differences in chronic pain compared to sickle cell or recurrent sickle cell pain. And we begin a plan to wean off all her opioid medications. She agrees to continuing transfusion therapy, intermittently tells us she's going to fire us, but then agrees that the transfusion therapy is helping, and she likes taking pictures of herself during her exchange transfusions. So when we look at opiate use and the use of opiates specifically for chronic pain, there are really no long-term outcomes in pain and function. And the placebo-controlled trials that are out there are less than 6 weeks long. We know there's a dose-dependent association with risk of overdose or other harms and side effects. There's very inconsistent results, and the risk prediction is very insufficient for saying, is this really going to work for an individual patient? Most importantly, there's no difference in pain and function in studies that have looked at dose escalation. So what happens in nearly anyone that you give an opioid to? In the short term, they absolutely get a pain relief. In the long term, however, various individuals have very different responses. Some do get pain relief. Some actually get long-term pain relief. Others, however, develop tolerance, dependence, hyperalgesia, which is an abnormal sensitivity in which people experience more pain. They can get medication toxicity. And of course, unfortunately, even some individuals with sickle cell disease could be genetically predisposed to addictive illness. It seems to be less in the individuals with sickle cell disease, but based on recent papers, about 5% remain at risk for serious addictive illness. And there's side effects: itching, nausea, vomiting, constipation, and sedation. There's also insomnia, dry mouth, mood changes, endocrine dysfunction, and decreased libido or sexual function or sexual interest, tolerance, dependence, and withdrawal. Last but not least, let's talk about Joshua. Joshua is a 41-year-old male, has SS disease. He lives with his mother. He's never been married. He's been on chronic opiates for his avascular necrosis for several years. He's followed in our clinic for many years as well. But he often comes into the ER at night and complains of pain and difficulty breathing that he calls a crisis. He takes the hydroxyurea. He's a very good hydroxyurea responder. And when you talk about his mood, he's actually very anxious. I met him right when I moved to Alabama. He's very worried something's going to happen and he's going to die because of his sickle cell disease. He had his gallbladder removed at age 20. He's had port placement ×2, and he's been in the hospital several times, but he's never required the ICU. Again, we talk about goals of care, looking at reassurance. What he really needs is reassurance that he can survive with sickle cell disease. Because remember, he's 41, and people told him growing up he was never going to live beyond 20 years of age. So he keeps assuming at some point he's just going to die. We talk about the new treatments that are out there, and we talk about his living situation. His mother is very supportive, but he's a 41-year-old male, and he really needs some other social outlets. And we talk about things that we can do to help motivate him in improvement. Again, he's very anxious about sickle cell disease, and we talk about how much anxiety plays into pain. and how while crizanlizumab can help decrease the frequency of acute crises, we also talk about transfusion therapy for the same reason, that anti-anxiety medication might be optimal. He agrees to start sertraline to help with daily anxiety. And more than anything, he wants to come in more often. He's been seen every 3 months prior to my joining the center, and he'd like me to see him monthly just to check him out and make sure he's okay. He's open to crizanlizumab or transfusions, but only wants to do one thing at a time and wants to start with taking the sertraline, and agrees to look at other possible activities to engage him with others. We're almost out of time, but I do want to point out several other medications that are both in development as well as those that have been developed. Medications that stabilize the cells by increasing fetal hemoglobin, or new medications like voxelotor and pyruvate kinase medications that are actually looking at stabilizing the hemoglobin by preventing the actual hemolysis. There's other medications attempting endothelial blockade similar to crizanlizumab. There are nitric oxide and cyclic GMP modifiers, and they're antiplatelet medications. And of course, there's stem cell transplant that was so well described and discussed prior to this discussion. So in conclusion, when we talk about individuals with frequent recurrent vaso-occlusive crises, you first want to make sure that you get as much buy-in and engagement with that individual as possible. You have to get on their point of view and see the world from them. Before initiating any new pain or any new therapies, we want to determine how you're going to evaluate effectiveness. We're going to talk about treatment goals, pain relief and function. We're going to set a time limit. If I'm going to start a new medicine, I want to give them 6 months, and I want them to agree to give me 6 months before we decide it won't work. Set boundaries. As I mentioned, we have a lot of opiates in the United States, and I don't want to be arguing with patients about their opiate doses. And then we want to assess their progress. One way of doing this is a PEG scale. What is their average pain? What is their interference with enjoying their daily life? And how does their pain interfere with their general activity? And what does this individual patient feel is clinically meaningful? Because it will be different for different patients. So we talked about pathophysiology, clinical manifestations and complications, and how we manage individuals with recurrent vaso-occlusive crises. And now I'm happy to take any questions that you have. Thank you very much.
Thank you, Dr. Julie Kanter, for this comprehensive presentation.
Did you want me to go ahead and read the questions on the chat?
I will put the questions.
صوتك ضعيف محمد، إذا ترفع صوتك. لا, come closer to the microphone, I think, or to the laptop.
Okay, now I think my voice should be clear. So the questions here.
ما زال ضعيف.
For management of sickle cell anemia, and now we'll go for question and answer. The first question I have here: in patients who need a chronic exchange transfusion, what is your best central line? Which line you use?
So I'm very sorry because I can't hear you very well.
Okay. Good. So I'll take this.
I do see the questions.
Okay, no, I will. Give me a second. This first question.
So I see the question about when we should extract blood. And I'm feeding back, and I'm not sure why.
So in patients with taking hydroxyurea, some patients, they might develop high hemoglobin. So when you take a venesection or you do phlebotomy for them.
So when we talk about phlebotomy, which is the question, there's no great data that says we should ever blood when we have started hydroxyurea. Because these individuals have blood cells that are now healthy with fetal hemoglobin, there's less use in actually taking out blood. However, there is some data in individuals with hemoglobin S, and this remains to be studied well. I also see the question about oxygen. When we think of oxygen with the treatment plan, I don't give oxygen during a routine vaso-occlusive crisis because all by itself, oxygen is not very helpful unless someone is already hypoxic or has low oxygen levels. And often I find when patients are placed on oxygen, they are not assessed as well as to if their actual oxygen level is lessening. So they become hypoxic and no one knows. So we only use oxygen if people are less than 94% on room air at baseline. In this question, in the era of COVID-19, how do we see the prognosis of sickle patients if they contract the SARS-CoV-2? So we have a registry here, and we've seen data out of the UK that suggests that individuals with sickle cell disease are at higher risk of severe infection if they have other comorbidities, similar to other individuals. So if individuals have renal disease or significant history of acute chest, they may be at higher risk, and they should be exchanged very quickly if they become hypoxic. However, in general, monitoring is still the way to go, and if they are not hypoxic, you can continue to monitor them closely. We are not seeing significant aplastic crisis with people with CoV-2, so that's a good thing. So would we consider aspirin or low-dose steroids for chronic pain patients? So steroids actually worsen sickle cell disease. While they may help in the first few days, most steroids cause neutrophil proliferation. And the more neutrophils, the more pain individuals have. So we've had actually more complications with steroids. And in fact, when I have some individuals who have other comorbidities like lupus or rheumatoid arthritis and are on steroids, we'll actually put those patients on chronic transfusion because they have such increase in pain from the neutrophils. Aspirin has been trialed in several studies, but has not been shown effective. That's also been true of prasugrel and ticagrelor. So I do think it could be helpful in a small phenotype, but we haven't figured out who the right patients are yet at this time. In sickle cell patients with iron overload on chelation, how should we follow them? Excellent question. So we certainly see a lot of iron overload. What we do in these individuals is try to follow them with a liver MRI if it is available, and we try to do those every year. If not, we do follow ferritin, but you need to follow the serum ferritin as an average because it can go up and down and up and down. So you need to look at the average every 6 months. So there's no question that that repeat liver MRI would be most effective if it is available. Can we use hydroxyurea with crizanlizumab? Excellent question. Absolutely, you can use hydroxyurea with crizanlizumab. In fact, I think for many individuals, multimodal therapy is going to be the way to go. So if patients are already on hydroxyurea and having breakthrough or recurrent crises, we'll often add crizanlizumab. And we encourage those patients not to stop hydroxyurea because the hydroxyurea is really keeping their red blood cells healthier and decreasing their neutrophils, while the crizanlizumab is affecting the endothelium itself. If someone comes in with acute chest wall pain, do we treat them as acute chest syndrome? That's also a great question. So if someone comes in with chest wall pain, especially sternal pain, which is very common because you can get avascular necrosis of the sternum, we will not treat them as acute chest if they're not hypoxic or don't have a change on X-ray if they only have pain. But if they're hypoxic or have a new infiltrate, then we will treat them as acute chest. One way of differentiating is specifically pain in the sternum or pain with palpation, which is uncommon in people with true acute chest. What is the role of transfusion or exchange transfusion in painful crisis in children? That is an excellent question as well. We know that transfusion can be very helpful when individuals come in with a painful crisis. However, we want to limit the blood exposure and the amount of iron they can get over time. So we try not to use transfusions for simple, uncomplicated pain crises. That means pain crisis without acute chest or other complications. We really try to avoid it because of their lifelong risk of a recurrent pain and their risk of iron overload or alloimmunization. We try to save transfusions or exchange transfusions, especially for life-threatening complications like acute chest or stroke. What is your experience with long-term management of pain in patients for recurrent osteonecrosis? That's an excellent question. The recent ASH, American Society of Hematology, pain guidelines actually came out and very specifically said that these are individuals with recurrent or with sustained osteonecrosis. These might be individuals who do benefit from long-term opiates. And in fact, that long-acting opiates should not be used in individuals who don't have a specific area of pain, but more a diffuse chronic pain syndrome. So if I have individuals, for example, with osteonecrosis of the hip, and they either cannot or don't want to undergo surgery, I will usually put those individuals on a long-acting opiate. When possible, I use methadone. I find it to be the least addictive medication and have less tolerance issues than I do for other medicines. I also encourage hip replacements when feasible. What about the new drug voxelotor? Excellent question. Voxelotor works a little bit differently. It changes the hemoglobin so that it holds on to oxygen longer and it delays the release of oxygen, which can delay the sickling. That's an excellent question in terms of whether we think it is useful for pain. The studies have not demonstrated a reduction in vaso-occlusive crises. We've started using voxelotor in my own program. We have about 15 individuals taking it, and we see very disparate results. We see some people who have a very nice hemoglobin response and they feel better. We see some people who have an increase in hemoglobin, but they don't feel any better and their pain hasn't changed. We see some people who have no hemoglobin response. And then we see others who've actually had difficulties tolerating it due to severe GI side effects. So in those individuals, we've stopped it. Voxelotor can certainly be used in combination with hydroxyurea. We saw that in the studies that were done, the HOPE studies, and that it actually can be very effective. And there's some suggestions that individuals on hydroxyurea, for some reason, have a better response. We've also used voxelotor in a few people in combination with crizanlizumab. We have been hesitant to use that combination in my center because both medications are so expensive. We want to start one medication and watch those individuals for 6 months, see how they're doing before we add in voxelotor, because it's such an expensive combination and we want to make sure we're maximizing our effect. But it can be used.
Well, great. Thank you, Dr. Kanter. This is excellent overview of sickle cell anemia and the veno-occlusive crisis. I know Dr. Mohammed Bakkar had an issue with his audio, but you went ahead reading the questions, so that was very nice, I guess. I thought it will cover all the questions, so that's perfect. One last question. So what's your experience with crizanlizumab now, when you add it to hydroxyurea? I mean, how impactful is it? How the patients feel? We have 1 minute to go. If you could cover this, just.
Yes, absolutely. So we now have 40 patients on crizanlizumab, and we're pulling their actual data together. What we've seen, though, is that most people have a very good response. Now, individuals like some of the ones I have described with bad chronic pain, we're not seeing as much of a difference. And that's likely because they have other psychosocial mediators of their pain. But I would say that 60% of our patients have had a really significant improvement with crizanlizumab and have wanted to continue it. I will mention there's some reports that people have pain that comes with the infusion of it the first few times. We've seen that very rarely, but if it does happen, we pre-medicate them with Benadryl, diphenhydramine, and then they don't have any more problems.
Right. Now, would you continue it for the until for how long? I mean, is it lifelong? Is it?
That's a really good question. My current plan is to continue it for 2 years, and then depending on how patients are doing, consider randomizing half my patients off of it and to see how they do. But it will be up to the patients too if they're willing to take that risk.
Perfect. Well, I think with that, we'll conclude our meeting. Perfect. Thank you very much, Dr. Kanter. And I would like to remind our attendees for the next week webinar, which will be on how I treat newly diagnosed CLL by Prof. Kanter, and we have what's the latest in redefining disease control in CLL by Prof. John Greben. So we look forward to meeting you all again next week. Thank you again, Dr. Kanter. Thank you, Dr. Bakkar, and see you next week.